hospital where we have lots of multidisciplinary meetings between medical doctors and psychologists and psychiatrists and social workers and nurses. I really love when people from different backgrounds kind of get together and share their different perspectives. So I really liked this idea. I'm a clinical psychologist in Australia, so apologies for any character defects being Australia might have, and also I guess more importantly that I don't know what time it is for everybody, but I probably picked a pretty uncomfortable time for people around the world. I don't imagine there's many Australians in here right now, but if there are, hello. I am a clinical psychologist, and that means sort of day to day I see lots of different clients in a hospital setting. I got a PhD in clinical psychology, which I completed about 3 or 4 years ago. I guess for the last over 10 years I've been just pretty obsessed with mental health and psychology issues, and I really love talking about them, so I'm happy to do this. I want to make a bit of a disclaimer at the beginning that these really are just my opinions, so I will be drawing on literature that I've read, but I just find these topics really interesting, and I like to approach them a bit philosophically, especially when we're talking about mental illness. I find that this is a sort of area that deserves a lot of sort of attention to the underlying philosophy and the ethical issues and all the complexities behind the concepts. But I guess the disclaimer that I really want to make is that I know that for many people mental illness is like a really tangible thing. It's a real day-to-day problem in their life that's not sort of abstract or philosophical. And so I just want to sort of let everybody know that I'm aware of that. At no point in any of my rambling am I implying at all that people who need help shouldn't have help. Quite the opposite. I've dedicated most of my adult life to helping people work through mental health issues, and I firmly believe that they should be at the forefront of our social attention and funding. So these aren't just philosophical issues for me, but I do enjoy talking about them that way. And I actually think that for myself and for a lot of the clients that I've worked with, having a more sort of nuanced view of what we're talking about when we're talking about mental health can be helpful. So let's just keep that in mind. And I guess the other disclaimer I'd like to make is that I know I'm talking to a lot of people with more of a physical biology background, and so sometimes I might use words like disease and disorder and illness interchangeably when I talk. If I really need to make a point that's based on any of the differences between those words, then I'll probably say so really clearly. But if I don't mention that, you can probably just chalk off me using these words interchangeably to a happy accident. And I understand that there are differences between these words. Where we talk about illness, we're usually talking about conditions that can't really be cured, but can just be managed. And when medical doctors talk about diseases, they're usually trying to differentiate these as conditions that aren't infectious. And that's why when we talk about disorders, we're talking about non-infectious diseases. And that's why in mental health, we tend to use the word disorder rather than disease. But I guess this might seem a little bit nitpicky, but I think that it kind of highlights right at the outset the difficulty in translating some of these biological medical terms into the area of mental health. And it points to some of the really fascinating issues around the obscurity of what we're actually dealing with when we talk about something like a mental illness or a mental disease or a mental disorder. But we'll get more into that as we go forward. There's a bit of a joke in some of the discussions that we have where people who are more, I guess, who have delved more into the psychological literature will become more and more and more used to saying that things are just complicated or it depends. And when they're asked questions, they can sort of just respond with well, this really depends on a lot of different factors. And I guess you could say that my talk today is a bit of a defense of that view that, that Too Long didn't read version of this presentation would be something like, it's complicated. But what I really want to do is start by just going over how we typically understand mental disorder from a sort of Western medical point of view in the DSM. But then I want to delve into like the issues underlying that in terms of what we understand normality and abnormality to be, what the cultural and historical perspectives are that sort of point towards different views of mental illness, and then different ways that we can conceptualize mental illness today in terms of all the different treatments that are available. I want to get a little bit controversial, I suppose, sometimes in talking about critical perspectives of mental illness. Some people, especially from the 70s, had a big movement of calling mental illness a myth. And while I think that that's a little bit of a blunt way to put it, what I'm, I guess, going to argue is there's a little bit of truth behind that, but it doesn't need to be a sort of kill shot to the idea of mental illness in general. So this might be a bit of a strange place to start, just diving straight into this huge list of mental disorders. But I guess I really want to just make sure that we're on the same page, first of all, starting at this sort of surface level and at the present time with how we sort of look at all the different types of mental disorders. These days, like what most people would understand as the framework for mental illness would be from the DSM or the ICD manuals. These are the sort of two big global authorities, textbook authorities on like what we would understand as mental disorders. And you can see this list I've got up here on the slide is all the different types of mental disorder, the different categories of mental disorder that are characterized in the DSM-5. I'll quickly run you down the list. And I guess the major reason that I'm doing this is to just give you a sense of the breadth of what we're dealing with when we're talking about something like mental illness, because there's a lot of common disorders that we talk about, but I guess when you look at them all at once and talk through them all at once, you get a sort of appreciation of the complexity of what we're dealing with here. And also, I want to highlight, and you'll notice this as I go through, that the criteria we're using to sort of define what is or is not a mental illness gets a little bit fiddly when we start to cover all of these really different human experiences. So really quickly, we've got this neurodevelopmental category, which is, we're talking about disorders that have an onset somewhere in the developmental period. So usually these are characterized by deficits in things like learning or executive functioning or intelligence or social skills, etc. So these are disorders like intellectual disabilities, language disorders, developmental delays. This is where we talk about autism spectrum disorder and ADHD and disorders like that. We have psychotic disorders, such as schizophrenia spectrum. We have a whole list of disorders in this category that all typically relate to things like delusions, hallucinations, disorganized thinking, disorganized behaviors, like catatonia and that sort of thing. And there can be a lot of negative symptoms as well, like a lack of emotional expression or a lack of motivation. Bipolar is a type of disorder which is sort of a bit of a bridge between psychotic and depressive presentations. So we have bipolar 1 and 2 disorders there. But these are basically conditions where people have depressive states and they also have manic states, which are like markedly different ways of thinking and behaving. We have depressive disorders, which we all kind of, I think, have a bit of a common understanding of. These are states where people feel sad, empty, or have an irritable mood, and there are sort of bodily and cognitive changes that impact people's ability to function. We have anxiety disorders. There's quite a lot of those. Generally speaking, they're about excessive fears or anxieties. So fears being like a response to an imminent threat that's in front of you, and anxieties being a response to an anticipated threat. We have obsessive compulsive disorders, which are sort of people's inability to control persistent thoughts or urges or images, or have repetitious behaviors or mental acts that they can't stop doing. We've got a whole lot of disorders related to specific events that have happened to someone that have given them traumas that impact their behavior in an ongoing way. We've got dissociative disorders, these disrupted or discontinuous states of consciousness where people kind of aren't integrating their memories or their sense of self or their emotions. They sort of lose conscious awareness of these states or can't integrate them. We have personality disorders where people have sort of long-term behavior that is really deviated from their culture and it's not flexible, usually comes up in adolescence or early adulthood, and it's pretty much stable over time. We have paraphilic disorders. Now, this is a really interesting definition here, which some of you might find particularly interesting when we talk about issues like normality and abnormality of human experience. Paraphilic disorders are like voyeuristic or exhibitionistic or sadist experiences. Now, listen to the definition here. So we're defining this as a disorder if there is a persistent sexual interest other than an interest in genital stimulation or preparatory fondling with phenotypically normal, physically mature, consenting human partners. Then we have somatic symptoms. So these are distresses related to like bodily symptoms and anxiety about illnesses and health issues. We've got feeding and eating disorders. So these involve altered consumption or absorption of food, and similarly elimination disorders, the inappropriate elimination of urine or feces, usually diagnosed in childhood or adolescence. There's a whole lot of disorders about sleep and wake cycles, usually issues with quality, timing, or amount of sleep, so things like narcolepsy or insomnia. Sexual disorders, typically these are impairments in responding or enjoying or experiencing sexual pleasure. Gender dysphoria, this is an incongruence between experienced or expressed gender and assigned gender. There are disruptive impulse control and conduct disorders. So these are all issues about self-control of emotions and behaviors. These violate the rights of others or cause problems with society or authority figures. There are different categories of substance-related and addictive disorders. These are all kind of understood as disorders that we know impact the brain reward system. So things like sex addiction and stuff like that aren't included yet. But what we're really talking about are usually drug, but also gambling addictions where we think that there's some kind of actual disruption of the reward system, which leads to compulsive behaviors. There are neurocognitive disorders, so things like delirium, Alzheimer's, things like that. These are acquired cognitive impairments. They're not from the developmental period. And then there are a big list of other disorders that don't quite fit into these categories. And I guess the DSM also tips its hat at a lot of disorders that are being studied but aren't formal diagnoses yet. So I guess, like I said before, what I'm really trying to highlight here, I suppose, is the breadth of what we're talking about when we talk about mental disorder, and also how the DSM-5 sort of varies in its criteria for understanding and marking out boundaries around what is a disorder. So you'll notice that in some of these categories, we're looking at things like biological markers, so neurocognitive and neurodevelopmental and substance-related types of disorder, for example, include in their description a sort of a biological component. Some of the disorders are really marked by personal distress, things like depression and anxiety or somatic symptoms, and others don't have this aspect of personal distress, but we're talking more about harm to others or a lack of harmony with society or authority. And so, in other words, the definition of what we consider to be pathological and what sort of differentiates mental illness from normal experience is somewhat flexible here depending on each type of disorder. So then the question is, do we have a broad understanding of mental disorder or mental illness that would sort of cover across all of these different types of experiences? What do we mean when we talk about mental illness or mental disorder generally? So prior to the DSM-3, the third edition of the DSM, the classification of a mental disorder was just based on the best clinical judgment of a committee and its consultants. And when the DSM-3 was being produced in the 70s, the lead of that development, this person called Spitzer, he argued that we really need, as a starting point, an atheoretical and value-independent definition of mental disorder generally. And this was sort of motivated by a bunch of different political movements at the time. Particularly, they were trying to justify flat-out removing homosexuality from the DSM classifications. And they also wanted to be able to counter some of the arguments that were being made by the anti-psychiatry groups. And what the anti-psychiatry groups of the time, they were criticizing psychiatry by basically saying that they weren't a medical field, they were a social and ethical field. In other words, their understanding of mental disorder was just a form of social control by sort of calling certain behaviors normal and other behaviors abnormal. And so by the time the DSM-5 came along, we have this sort of evolved definition, which is very broad, very comprehensive definition of what we mean by a mental disorder. Now, note the important features of this definition, right? So it's clearly saying that we're not considering culturally approved behaviors to be a mental disorder, and we're not including pure social deviance as being a mental disorder. We're talking about an individual who has some kind of dysfunction in the psychological, biological, or developmental processes that leads to clinically significant disturbance in cognition, emotional regulation, or behavior. And it's usually, but not always, associated with distress or disability in social, occupational, or other important activities. So why do we need this definition? I've already given you some of some of Spitzer's arguments about why it's needed. Even these days, the DSM puts forward a justification in the intro to its definition. We need a definition of mental illness so that we can guide our research. We want to have clear defining constructs that we can investigate the causes and the outcomes of mental disorders. We want to be able to inform society, like about prevalence rates or common causes. We want to guide treatment recommendations. But I guess broadly speaking, what we're really doing here is inferring responsibility. And we do that in a couple of ways. By calling something a mental illness as opposed to a normal experience, what we're doing is we are saying that this is firstly a problem that can be located usually with an individual. And secondly, that the problem belongs, so to speak, to the mental health sector. In other words, like, this is an issue that should be addressed by our mental health teams. Ultimately, in doing that, what we're doing is distinguishing between abnormal and normal experiences. And some critics would argue that it's as a tool of social control. I would say, of course, it's a tool of social control, although that might not be malevolent. It might be a very helpful thing. Most people who go to see a therapist want more control over their life, and especially over experiences that they find distressing. So I've put in this quote by Tels Carreira, Saraiva, and Goncalves. They are looking at current definitions of mental disorder, and they rightly point out the determination of biological or even psychological dysfunction in most psychiatric disorders is difficult, controversial, and usually the result of influenceable theoretical currents. In other words, when we look back over those different categories of mental disorder that I mentioned earlier, it's really difficult to take any one of those, let alone all of them, and pinpoint to say this is what is causing the problem. The way that we understand mental disorder is influenced by theoretical currents. And I would argue that actually this is a much larger problem because the way that we understand mental disorder and mental illness is influenced fully by our culture. When we had the anti-psychiatry movements sort of growing in the 60s and 70s, a lot of this was the foundation for this was laid by anthropologists, because anthropologists, especially like in the earlier 20th century, these were the people who were going around and looking at all the different global cultures and starting to piece together and realize that different cultures have really radically different ideas of what's normal and what's abnormal. So, for example, we have anthropologists who start telling us that certain Zuni tribes think that possessing property or having like an uninhibited drive or ambition is pathological or deviant, right? And they would either punish or try to cure that state. We know that like Northwest Coast Native Americans, they had like insult complexes where it was really normal to interpret events that were happening in reality in terms of a personal insult that needed retribution. Things like even accidental deaths and stuff were sort of cured by getting revenge in some way, in a ceremonial or a headhunting way. And then we have a whole lot of different groups who practice like religiously motivated hallucinations, visual and auditory hallucinations, or trance states. So different cultures have these really radically different ideas of normality and abnormality. But cultural deviance is not enough to infer that something's not normal. That's just a matter of compliance. So even if someone goes against their culture, we wouldn't say that that's inherently pathological, because we would just call that deviant. And even the DSM-5 makes that really clear. We can't just say that like a political or social disagreement is inherently pathological. And we also can't say that statistical adherence implies normality or abnormality, because, we know that things like depression and anxiety are really common, but we would still call them pathological. Things like I mentioned before, drive and ambition might be really rare, but we wouldn't want to call that pathological either. So we can't use, we know that culture affects this, but cultural and statistical adherence is not enough to say that something's abnormal. So how do we define what's normal and abnormal? And I really like this take by Wagrocki, who was one of the early anthropologists who tried to answer this question. He said that abnormality is a tendency to choose a reaction which is an escape from a conflict-producing situation, but doesn't face or resolve the problem. So in other words, we can't look at any one experience and say that that's abnormal. It's the function of it which determines its abnormality. It's whether someone is capable or willing or able in any way to resolve their own problem. And to the degree that they have a distressing problem that cannot be resolved by what they're already doing, we would call that a pathology. So I mentioned before, we have all these different theoretical currents that have different understandings of what we would call psychological illness. And Ellenberg is another sort of researcher who looked at a lot of the anthropological evidence. And we can see that like way back in prehistory, we have different techniques where healers were trying to help people fix their psychological illnesses. And they had certain beliefs and ways that they talked about what was going on, like a loss of the soul or a spirit intrusion or a breach of taboo or sorcery. And then they had specific techniques that were used to help with these problems. And this went all the way from prehistory to through history, and eventually sort of evolved into, I suppose, religious healing, where we have even the major world religions sort of offering religious healing for psychological problems. That was the worldview that was used to understand what was going on and what would help. Then we have Mesmer, who came along and had this first quote-unquote scientific theory of mental illness, which he called magnetism, which was basically hypnotism. It's interesting that Mesmer we talk about people being mesmerized. That comes from Mesmer's work. And also what a lot of people don't realize is that we talk in psychotherapy about this concept of rapport. And rapport is another concept that was introduced by Mesmer. It was a, quote unquote scientific connection that facilitated like a magnetic link between the advertiser and their patient. These days we still talk about the strength of rapport between a therapist and their client. So all these hypnotic ideas about fixing psychological disorder through hypnosis were really developed by Charcot. And he developed this idea that there were these fixed ideas that could be accessed through hypnosis and resolved. Genet continued that thread and talked about the idea of the subconscious. He was the first person to sort of really widely speak about the subconscious and the idea of fixed ideas being sort of located there, and that we could use hypnosis to bring those into consciousness and resolve them. Freud was really influenced by this, but he eventually, as we know, dropped hypnosis with his new method of psychoanalysis and further developed these theories where we could access unconscious neuroses and heal them by talking. What I'm trying to point out here is that we have not only the current sort of DSM definition of what's a mental disorder, but these cross-cultural ideas of mental disorder and then these historical ideas of mental disorder, which really characterize what we understand to be the issue and how we're going to fix it. And these days, we fast forward to having pluralized all these different diverse theoretical currents, which all, I would argue, have their own ideas about what causes biological and psychological dysfunction. And so I guess what I would argue is that each of these different theoretical approaches, and there's many more, that's why I put etc. here, I've just put a few examples, each of these have their own conceptualization of how to treat mental illness and in effect what we even understand mental illness to be. I'm going to run through a few of these. We talked before about, the development from early sort of spiritual and religious worldviews, which had their own sort of ideas about spirits and souls needing to be addressed, and that sort of was challenged by this idea of hypnotism. Although that hypnotism led us to develop these theories about the subconscious and the fact that we have these complexes and neuroses that we can locate somewhere in the subconscious and access first through hypnosis and then through just talking, and other techniques like, free association. All of this sort of suggests that we have this repressed content, right? So somewhere in our psyche, we repress distressing content. And the psychodynamic perspective, to put it really bluntly, is this idea that the act of repressing content has an energy cost. Because, when we talk about a dynamic system, we're saying that if you use energy in one place, that energy is not available in another place. And so it has an energy cost to be repressing things. And it has an impact on our behavior because in order to keep repressing that content, we need to be avoiding certain things either mentally or behaviorally, right? So we have all these diverging psychodynamic perspectives, which sort of, I guess, disagreed in what they emphasized as the primary things that people were motivated to repress. Freud is famous for really focusing on sex and aggression, the idea that we are trying to not be aware of our own animal instincts because it would be too dangerous to be aware of those, especially as children. If he argued we wanted to sleep with or kill our parents or other siblings, for example, and so we have to repress these things. Adler sort of broke away from Freud and had much more of a social perspective and said that our primary repression is our sense of inferiority and powerlessness and I suppose a general fear of our own ambition and our own drive to succeed and overcome other people. Jung broke away from both of them to sort of talk about repressing our access to what he called the collective consciousness, or the collective unconscious, I should say, and also the process of individuation, where we are sort of repressing our own drive to become, as he would probably put it, who we really are. Then we have a whole strand of existential therapists who would argue, and this is having a sort of resurgence these days, even in fields like CBT, who would argue that the primary thing we're repressing is our awareness of death. You know, there's lots of evidence that kids realize that they're going to die when they're about 6 or 7, you know, and most people, even when they believe that death is a permanent state of non-existence, it's a wonder that they don't think about that every day all the time and feel really fearful of it. So a lot of people would argue that that's the primary thing that we're repressing. And then others would argue that we repress our initial experience with attachment figures, and we are unconscious of our styles of attachment with other people and our object, are sort of representations mentally of how we stand in relation to other people. I really like this quote from Becker, who wrote The Denial of Death. He sort of summarizes this: the great simplification of psychoanalysis is the concept that all of our early experiences is an attempt by the child to deny the anxiety of his emergence, the fear of losing support, of standing alone, helpless and afraid. The child's character, style of life, and way of using the power of others, the support of the things and the ideas of culture, is all to banish from awareness the actual fact of natural impotence. Not only impotence to avoid death, but to stand alone, firmly rooted in his own powers. So this is one strand of how we might characterize mental disorder and mental illness and how we're supposed to fix it. We're supposed to make these repressions conscious again so that people can face them. We have a whole lot of behavioral perspectives, which would sort of think of all behaviors, internal and external thoughts and actions, or whether we consider them normal or abnormal, all as learned interactions with the environment. So we are the product and the producer of our environments, and we first accidentally are victims of classical and operant principles that condition our behavior, but we can therefore use those same principles to functionally learn and change new behaviors. And I've got a quote here that's by Watson that sort of exemplifies what he was on about at the time. Psychology is, and I would argue mental illness, as the behaviorist views it, is a purely objective experimental branch of natural science. Its theoretical goal is the prediction and the control of behavior. Behavioral perspectives were sort of expanded with Beck and the cognitive behavioral approach. So with CBT, we can recognize that psychological problems might be rooted in childhood, but we're often much more interested in the current ways of thinking that people have, and that the idea that these perpetuate their problems. And this can get traced back to sort of the Stoic philosophers who talked a lot about all emotional distress as being a product of our thoughts. Thoughts and beliefs are seen as the cause of disorders. And if we want to sort of address and fix mental disorders, we want to examine the faulty assumptions that we have and replace these, if we can, with more accurate and effective beliefs. And we also want to help people to develop like a metacognitive awareness, that is like an ability to look at the way they think and look at the way they develop beliefs so that they can manage this process. Another perspective of mental distress and mental health is the humanist perspective. So the idea here is that humans are seen as having a really natural inclination to grow and develop in a functional way. And Carl Rogers is the guy who sort of really pushed the humanist perspective through person-centered therapy. What he sort of saw as mental disorder was a barrier for someone's growth. And so he was looking at what are the conditions by which people will naturally grow to their sort of ideal self. And he saw that primarily as being in the context of a specific kind of relationship, not just with the therapist, but he analyzed therapeutic sessions to sort of try to figure out what does a relationship need to look like for someone to naturally continue growing along their natural path? And he came up with these sort of famous criteria for the relationship, that the therapist wants to have empathy for the person, congruence, which means that the therapist is somewhat authentic, what is happening inside their emotional and thoughts is expressed, and they're not lying or distorting things to their client, and that they have unconditional positive regard, which doesn't mean that you validate everything that the client says or does, but just that no matter what they say or do, you sort of have this humanist perspective of them, where they are trying to spontaneously grow towards the best version of themselves. There are some perspectives that don't just focus the problem inherently on the individual. So family and systems perspective of therapy have not only a different way of working, in that they will treat an entire family unit rather than an individual, but a whole philosophical way of viewing problems as systemic rather than sort of isolated in one person. The theory here is that mental disorder is a reflection of how a person has adapted to a whole family system. And if you change one part of the system, every other part will inherently need to adjust in order to sort of respond to that change. So we're looking here at interactive and systemic perspectives of what disorders are. And then there are perspectives of mental disorder and therapy which expand that view even further. So an example of that is a feminist perspective, which is also a systems approach, but it's looking much broader than even the family unit towards like cultural, social, and political factors that will all contribute to a quote-unquote individual problem. And so from a feminist perspective, they would criticize a lot of the traditional theories of mental illness, seeing them as sort of gender biased or ethnocentric or gender-centric. And the goal, therefore, of helping people to overcome mental disorder or mental illness would be to sort of help them realize the strength that they have to free themselves from those socializations. And I guess not only that, but the goal is not just individual change, but wide social change in policies. And so people in this sort of therapy are encouraged to make changes to institutions where they can. So all of these different perspectives, as I said, to me are sort of evidence that we don't have just one overarching way of understanding what mental disorder or mental illness is. And it points back to that sort of quote at the beginning that we really actually still to this day struggle to sort of point at any one of those categories of disorder or disorders broadly and sort of give a clear explanation about what is causing this issue. The causes that we posit for mental disorder really depend on cultural and theoretical currents, and they all then offer different sort of avenues for helping people to resolve the issues. I want to just acknowledge therefore, I suppose this anti-psychiatry claim that mental illness could be a myth, right? So SARS was one of the big anti-psychiatry proponents in the 70s. He was a trained psychiatrist. And he said that he was really pushing back, I suppose, against this one view of mental disorder as a biological problem. And I find that it's still interesting to sort of consider his arguments because they're quite straightforward, really. He argues against the idea that mental symptoms are signs of brain disease. If we're talking about brain damage, he would say, then we should just own up to that and say that we're talking about brain damage. If we're not talking about brain damage, or some kind of physical illness of the brain or the nervous system, then the word illness there is really misleading. because what he would argue is that we're really just dealing with problems of life, right? Problems that come up when people are trying to grow and get along with everybody else. And I find that that's still quite a compelling argument, because most people, I would say, find it a bit tricky to sort of resolve this idea that they don't believe in a non-physical mind. They would sort of reduce things to a material worldview, but then they wouldn't also feel comfortable saying that all of mental illness is brain damage. The thing that that a lot of people would then go to is that it's some sort of imbalance in neurotransmitters or some kind of brain state that is undesirable. And the difficulty with that sort of claim is, well, firstly, it's quite challenged by like modern evidence into this theory of an imbalance in neurotransmitters. Just empirically doesn't seem to hold that much water when we're trying to point to the cause of certain disorders. But more than that, it implies that we have this kind of ideal goal in mind about what a human brain and nervous system should experience and what it should be able to do, which I would argue is, again, a sort of an ethical issue rather than an empirical one. So SARS would say that the notion of a mental illness functions as a convenient myth. He sort of also would say that we're sort of tracing the spiritual and religious myths to come up with our own sort of explanations about what we think is going on, which ultimately sort of act by kind of just making the whole thing a lot more palatable by saying that this thing exists that we will call mental illness, and we will therefore be able to treat it. His argument is not, by the way, that people shouldn't get help for problems in life. He's not even inherently saying that psychiatry shouldn't exist. He, I suppose, was pushing more for psychiatrists and people in general to own up to the fact that they're prescribing social and ethical issues rather than biological and medical ones. So where does all this leave us? One more quote by SARS. He would say that we don't have an enemy that we can fight, exercise, or dispel by cure. What we have are problems in living, whether these are biological, economic, political, or socio-psychological. So I probably wouldn't come out and simply say that mental illness is inherently a myth necessarily. Where I would acknowledge that it might be a myth is more to say that our understanding of mental illness is influenced by theoretical currents. It's influenced by the cultural worldview that's used to explain what causes mental illness, and therefore those different cultural worldviews also prescribe what we should be doing about mental illness. We don't, in calling it a myth or like a social construct or something like that, that we don't have to then say that we need to get rid of them or they're somehow wrong. We can just adapt to them and make sure that they're working for us. I would see it not as a problem necessarily that we have all these different ways of understanding mental illness. I would say that they're all helpful where they actually pragmatically help. We have this really diverse description of mental illnesses or problems in living, whatever you want to call them, outlined in the DSM-5, this kind of catalogue of what people have seen over the years in terms of distress. We have all these diverse perspectives on what might cause mental illness and what we could do to treat it, and the conditions that seem to make people grow and develop in a healthy way. And we can acknowledge that these are influenced by culture and worldviews and ethics, but that doesn't mean that we need to get rid of these different tools that we can use. Thanks very much for persevering with me, those who have, and I'm happy to chat more if people have questions or comments. So I'm just going to stop sharing my screen and then I'll keep chatting. Actually, I'll hold on just 1 second. I'll go back to this slide here. How did people make these different categories? Well, firstly, it primarily is expert opinion. And so the different iterations of the DSM are developed by task forces. So these are like, they gather together who they see as sort of experts in different strands of clinical disorder. And these people, I suppose, compile their expert opinion and all of the evidence that we have about common causes, common presentations, common outcomes. And so it's really, there's really no, I suppose, single criteria that's used that each of the different types of disorder has to meet. Each type of disorder is, I suppose, put together by a panel of experts using any evidence that they have that they think is robust enough to justify that category of mental illness. Yeah. I actually am not sure how organizations like the APA will put a deadline on when it's necessary to have a new version. You can see in the DSM-5 even they've included a whole lot of different descriptions of current research going on into disorders that they wouldn't get diagnosed, but they think are worth investigating. So, I guess they're aware that there are all these different strands of research that are likely going to change all these categories in the future. But I don't know when it's a tipping point and they feel that there needs to be an update. I think historically that's probably been urgent, like made more urgent by different reasons. So like I said, the DSM-3, I whenever I've read about the development of the DSM-3, it seemed like there were a lot of political pressures of the time, which were really encouraging the organization to put out a new version that could correct some of the problems that people saw there. And so I think that it's kind of probably a mishmash of like political, legal, and psychiatric evidence that kind of eventually makes the release of a new version more urgent. But I don't think I could probably give you like one criteria they would use to say we need a new version now. My guess is it's all being worked on now, it's just a matter of when it gets sort of put into a position where they feel comfortable updating everything. So it really depends on the type of disorder. And you can see that some of those disorders will use like the causes of the presentation as a criteria. So for example, like post-traumatic stress, to get a diagnosis of post-traumatic stress, we really need to pinpoint in someone's history a traumatic event that happened we would argue is causing the current experiences. And similarly for like biological stuff, some types of disorder like neurocognitive disorders, we really need to pinpoint biological impacts. Others like depression just describe what a person's experience has looked like for the last weeks or months, to say they've had these experiences of these moods or these thoughts. And the causes of that are not included in the disorder. And so it really depends. Some, new things like gender dysphoria is really just describing someone's current experiences. It's not going into a huge body of evidence about what that means biologically or anything like that. So I guess this is what I mean by the fact that there's so much variance across these different types of disorder. What type of evidence is used to justify them? I don't think Freud would. Nothing I've read of Freud would say that he would argue women are okay with this. My reading of Freud in the area of like women's place in society was obviously it's pretty fucked, some of the stuff that he said, because he was living in that time. But when you read things like his book, The Civilization and Its Discontents, like what Freud was running up against was a kind of Victorian era where a lot of people were going around in his time with the attitude that we had reached some kind of pinnacle of civilization, that people were, using science and all these things to just create a wonderful society, and that we were, all doing really, really good. And then when he was doing his work on psychoanalysis, he had a lot of women coming to him saying that actually behind closed doors, this is all, like, a lot of stuff is really awful. And so it's interesting because a lot of people would sort of describe Freud as a sort of wake-up call to how bad the situation actually was. And a lot of the time, a wake-up call for how bad the situation actually was for women, in that, the areas that people generally didn't want to talk about, sexuality and aggression and stuff, were causing a lot of problems within relationships and families and that sort of thing. He did have a lot of batshit ideas, and he was not like a champion of like feminism as we would understand it today. I'm not trying to make that claim at all. I'm just sort of saying that I don't think he would ever have said that like women are okay with what was going on. I think a lot of what he was doing was the opposite. He was trying to draw attention that there was a lot of dark shit going on in society that people did not want to acknowledge at the time. I've got no idea about how we would sort of understand mental disorder in animals with less developed prefrontal cortexes. I just don't know off the top of my head how we would sort of understand different behaviors in animals as disordered or not, and then if we did, what the prevalence of that would be. I guess, again, I would probably just give a bit of a probably unsatisfying answer to that question by saying that whether we would implicate the development of the prefrontal cortex in mental disorders is really going to depend on what mental disorder we're talking about in the first place. I guess, like, again, I don't think many people would look at animals and call those issues like psychological disorders if we saw that their behavior was somehow like dysfunctional. Just don't think we would probably use that lens a lot of the time to talk about animal dysfunction. I guess I would find that a really difficult question to answer without knowing the details of your professor. I mean, I've had most of my colleagues when I was going through postgrad had problems with their supervisors and professors, and at some point had some interpersonal conflict, and some of the professors were really sophisticated and good with that kind of stuff, and some of them were really awful. So, I wouldn't want to say something like, "Oh, just talk to them about it; it'll be fine." Because if they're not equipped to handle that stuff very well, then it might not be fine. I would probably get some advice from a therapist who you can have a bit more time to explain what your professor is like, what kind of problems are coming up that you feel like you need to talk about your distress and that sort of thing, and kind of come up with a bit of a plan with a therapist. That's what I would recommend. I think the two big issues that I run up against in a lot of my work, I work in a hospital where we encounter a lot of people who we would probably say need psychological support, but are really resistant to it. And a lot of the time it relates to some of the stuff I was talking about in terms of like cultural understanding of what problems mean, and what it therefore means to get psychological or mental health support. Sometimes that's like cultural backgrounds that really don't trust mental health theories for whatever reason. It just doesn't gel that well with their way of understanding the world. And a lot of the times there's really specific cultural factors that sort of make people really resistant to therapy. So like, for example, a really big one at the moment that I've been looking into a fair bit is masculinity, because a lot of ideas of masculinity kind of encourage men to not seek support because, for whatever reason, there's a whole lot of beliefs and baggage about what it would mean to seek support. And a lot of the time that seems to relate to like men feeling like if they were to seek therapy, they would be a burden on other people, and it's an indication that they are broken in some way and therefore not valuable to society and that sort of thing. I meet a lot of men who have those sorts of beliefs. And there are some cultures, like, for example, Greek culture, a lot of men I meet from that kind of background have that kind of worldview really enhanced, and it can be a big barrier to mental health support. And so I think it's not enough to just kind of like come out and say you need to just adopt our view of mental illness and mental health. I think it's really about kind of like trying to figure out how we can meet people where they're at. So like I'm doing research at the moment and doing projects to try to like figure out how we can engage with certain types of men who would be really put off by therapy, and not just browbeat them with like my own facts about mental health, but instead kind of like really get to know their values and their worldview and their reason why it would be so awful to sort of engage with the way that I view mental illness, and try to come up with some kind of like compromised view of what's going on. Well, the obvious answer to that, I suppose, from a scientific perspective, is like researching it. And so, there are lots of different clinical trials that happen where we have control groups and experimental groups where people are sort of using different types of therapy to help with different disorders, and those different types of therapy have different assumptions about how to fix the problem, and therefore like what's actually going on with that problem. And we can use sort of research that way to sort of guide our understanding about what seems to help the most. Then I suppose on a more individual basis, when someone has a certain disorder or a certain experience, they might have personal factors which make one way of understanding it more helpful than another way. So, for example, I met this one guy when I worked in a psychosis clinic who had seen lots and lots and lots of psychiatrists and psychologists across his life. And he had always had it explained to him, his sort of psychotic experiences and paranoia were always explained to him from this kind of perspective of biology and neurology. And he honestly tried to engage with that perspective as best he could and use the techniques to kind of recondition his nervous system and all of that. And it just never seemed to jive with him. And what he really responded to was a sort of view that his state of paranoia was an adaptive function, and to sort of value that as a state that he could enter into and leave when he wanted to. And it wasn't until we just acknowledged it as like a functional thing for him, his paranoia, that he eventually found he could sort of change. And so I think on the one hand, we've got these really broad research programs to try and figure out what will help with certain disorders. And then the caveat to that is that individual people are also going to have their own personal factors, which sometimes need a bit of trial and error to sort of figure out what's going to help. Sometimes, I guess, a lot of people get really worried about, people self-diagnosing or talking about their own personal psychological issues and stuff like that. I usually get more worried about in the opposite direction. I get more worried when psychology is kind of put forward as a really unified authority on these sorts of things, because as you might have gotten the picture from my presentation, my own personal view is that it's really complicated and really culturally dependent. And so I think it's more misleading if psychology is kind of characterized as this one kind of strand of authority on these things. I think that has a likelihood to put a lot more people off than a plurality of perspectives and that sort of thing. I guess, yeah, I think probably the more damaging presentation of psychology to other disciplines is that we're sort of, a therapist is sort of arrogant and will immediately know what's going on with someone and have a really closed-minded way of viewing their problems. That to me seems more risky than anything else. Yeah, I think that's probably all I would say on that. Yeah, for sure. You can go back to this definition. This is how the DSM put forwards what a disorder is. But, look at all the wriggle room. We've got, and I'm not saying the wriggle room is bad. I'm saying it's just, it's really broad. We've got psychological, biological, and developmental processes that are indicated. And then we've got cognitive, emotional, and behavioral disturbances. And then it puts in, as you say, this idea that it's going to depend on the culture. So we don't want to just look at someone's culturally approved response to something and then call it pathological. Different cultures, for example, have really different ways of emotionally and behaviorally responding when someone's died and going through the grief process. And so we really need to be careful about sort of understanding the different cultures that we're engaging with when we're sort of trying to work out whether we're going to diagnose someone or not. And then, yeah, as you said, like our different understanding of the psyche as well is really going to influence what we understand to be pathological or not. Some people will sort of look at really extreme emotions and really extreme experiences and say that that's a very natural function of the psyche. Other people would not even really use the word psyche and would sort of defer more to a sort of materialistic way of viewing things, which is probably much more likely to, just as you say, look at the function of these things. It's sort of interesting, like when you start looking at functionality as well, about, like say, for example, if someone can work or not, and using that as a criteria for how we're going to understand whether something is a disorder or not. Because especially these days, we're getting, I think, more and more mental health awareness, and alongside that, we're getting more and more of an appreciation that actually people can function quite well sometimes, even when they're experiencing a lot of distress. We have these terms like high-functioning depression and stuff like that, or people might have a trauma disorder that's triggered in certain moments, but they're trying to get along with their work life as best they can. So functionality to me is not like a single indicator of whether there's a disorder or not. We've got workaholics too, who might be, quite functional in some ways, but then notice in other areas of their life there are disturbances. You see here that we've got, in the DSM definition, it mentions disability in social, occupational, or other important activities. So that leaves a lot of room open to not just kind of like hone in on one aspect of life and say, as long as you're doing that okay, you're fine. We don't really want to like use that as a singular understanding of a disorder. Yeah. So I suppose it's probably important to just keep in mind that we have a lot of diagnoses in the DSM and in the ICD that are not in these major categories, but they are they're sort of acknowledged to be quite transient. Things like adjustment disorder and stuff like that are acknowledged to be more transient than anything else. And so if you were to, say, diagnose some, I would say it's probably an incorrect diagnosis to talk about something like major depressive disorder if it could otherwise be explained by adjustment disorder, which is talking about, a specific event that has just happened. But I guess the broader, to answer your question a bit more broadly, I thought that I would struggle as a clinician to diagnose people because I thought that would be something that was necessary most of the time, and it would be really hard work and all of that. I find most of the time I am helping people to not diagnose themselves because there's a kind of sense from people a lot of the time that they are pathological, when I don't think that a pathological label is particularly helpful in a lot of cases. Sometimes it can be. Sometimes it can be a real relief for people to sort of see that there's actually heaps of evidence and knowledge behind what they're going through, and they really like to see that they can fit into a certain category that we understand really well. Other people, it carries a lot more stigma, and not just personal stigma, it can carry interpersonal stigma as well. And so there's a huge body of evidence around like the impact of labels and that sort of thing, and the stigmas associated with it. And I find that research quite interesting, but at the end of the day, I really try to have a case-by-case perspective about each individual person as to whether, talking about a diagnosis is helpful or not. And then when I do sort of talk about a diagnosis, I want to make sure that I me and them have the same understanding of what we mean by that word. You know, I often talk about the DSM as a dictionary rather than anything else, and its goal primarily between me and a client, if I'm going to use the language of a diagnosis, is to just make sure that me and the client have like a shorthand way of understanding what's going on and a shared language about what's going on in a way that makes sense for them. And so if I am going to give out a diagnosis, really important to have like quite a nuanced conversation about what that means. I think that these days we've got a pretty holistic model a lot of the time. So you hear the term talked about a lot, the biopsychosocial model of mental illness. And, you know, what we mean by that is that we are really trying to make sure that we understand there is a sort of interaction between these different domains in how mental disorders might develop or how they're expressed. And I think that holistic perspective is really useful. I mean, you probably sort of got the tone from the presentation as well, that for me, I guess I'm a pragmatist. I think that the models that we use for mental illness and mental health should really work for us, and that primarily the more different models we might have to understand what's going on, the more we can figure out, I suppose, statistically across a lot of cases what's likely to be helpful, and individually, case by case, how people are going to be helped by understanding things as either biological or social or psychological. And so I think I like to just have more and more models, more and more theories at my disposal. And you know, when we have multidisciplinary meetings in my work between these different sort of fields, and we have medical doctors sort of reducing the client experiences to, say, their illness or their medication, and we have sort of psychiatrists talking about psychoanalytic theory about what's going on for them, and we have me sort of throwing in a cognitive behavioral perspective about what's going on, and then we have like social workers sort of talking about how complicated their life situation is and how that's what's going on, and they need practical help sorting out finances and things like that. We're not really trying to come up with like which of these theories wins in explanation. We're trying to have like a really sophisticated, holistic understanding of what's going on, so that we don't sort of lose sight of anything that could be important and could be helpful. And we usually have like the more complicated a case is, the more we might want to bring in professionals who have these different backgrounds and different expertises to help in different ways, because I would see all of them as being useful when they're needed. I don't, just to say thanks again, and they're really cool questions, and I really appreciate the invitation. It's a great idea. As I was just sort of talking about multidisciplinary stuff, I guess the spirit of that is really captured by these guest lectures where you bring people in from different backgrounds and stuff. So it's, a really cool idea, and thanks for inviting me. Thank you.
Thank you.